You ready? Hi, everyone. So we have Dr. Rubin here. Got some neck pain, some chronic, a little bit of acute stuff. Do you want to tell us what you're dealing with here?
So I have two newborn babies and they like to sleep on me. And so I have bicep tendonitis. It's going into my cervical spine, my traps, and then sleeping in the soft bed last night. My neck was killing me. Nope. I had a headache, I had a migraine, and a lot of pressure in the base of my head.
Okay. So that's what we got to fix, right? So as any good osteopathic physician would do is I'm going to start down here. People watching might be like, dude, her pain is here. But I know that we're going to start here anyway because, this whole system is connected and integrated. So tensegrity, right? That's the principle we're operating with. So I'm going to check so she has an anterior talus on the left side. That's going to come with its own things. Do you mind resetting for me? So knees up, hips up, good. Slightly, not by much, maybe barely a little bit longer on this side with an anterior talus. I'm just going to lift the heels, feel for long lever pull. So she's a banana right now. Her whole body is kind of side bent to that right side. And that'll come up later when we get to the axial skeleton here, the lumbar, thoracic, cervical spine. I'm feeling a pull in her left hip flexors as well. So her hips are slightly rotated as well to that side, that right side. I'm guessing she has an anterior left innominate too. I'm just going to check hips here. Yep, so she's got an anterior left. Okay, I knew that because as I spring, this side on the left side doesn't quite like to spring as well as the right. I'm going to check PSIS and just see. Yep, so this PSIS on the left side is also a little bit higher. So what we're dealing with is that kind of innominate going on. So what I'm going to do, we'll treat that left innominate. Any audience questions? Anything? No? Okay. I like that she wore very roomy pants today because it makes my job easier. If you ever have a patient with like restricted garments, you can always give them a pair of ortho shorts or ask them to take their belt off. I'm just starting with some articulation here. So I'm going to check full range both ways. I find a lot of students are too shallow and like not quite as deep as they should go. So really test her range of motion. As we get to internal rotation here, I'm keeping in mind that FAIR test, right? Checking for any piriformis restriction. Any pain when I do that?
A little bit. Yeah.
How about external? How is any of this stuff?
Yeah,
a little anterior there. Okay. So this is a technique I kind of, I guess, fell into over time where I bring this left leg into like almost a counter strain position. I get my hands into the iliacus and the psoas pretty deep. Any pain when I push like that?
A little
bit,
tightness,
a little tightness. So what I do is I bring that leg into a slack position, which is flexion, abduction, and external rotation. And I'm just doing some articulatory / soft tissue / MFR, feeling for restrictions. As you find over time, you're going to end up combining a lot of techniques just based on your style. So that's kind of my style. I'm going pretty direct. So your patient, you'll have to let them know if this is not tolerable, then they gotta just let you know. But you can sense, that by tissue guarding, by their face, by a lot of nonverbal cues. So I can tell she's okay with it as I make my way through. I'm gonna check glute. So that feels tight. Yeah. Push towards me. So some muscle energy, PIR, and relax. And push again. Good. And relax. And again. And relax. So note how I'm actually altering the angles when I'm pressing. I'm even playing with some rotation of that femur and that hip too as I check, push towards me, and relax, and push, and relax. Okay. So, and then as I do a still technique out of it, I reassess here. Now keep in mind, now she's even and things are moving well. The reason I'm switching, because remember I diagnosed from this side with my right eye over midline. I switch because I actually, and you have to know what eye dominance you have. I have both. So some people are ambi-eye dominant, some people are left eye dominant, some people are right eye dominant. To know, you have to, create a window, have something in the distance framed in the center with both your eyes open. You close one eye. With my right eye, it's still in the center. Close one eye. With my left eye, it's still in the center. Most people, one eye is going to have it in the center, and the other eye, that thing is going to be blocked completely. So whichever eye you can see that distant thing in the middle of your view, you know that's your dominant eye. So you always want that over the midline. But in any case, she's now even. Okay, so now we make our way up. Knee rotation, torsion is okay. I'm going to check now this side shift test is something that I like to do where I take the whole lower rib cage and this innominate and just kind of compress kind of this way. So gives me a sense of what might be side shifted. She has a slight side shift preference to this right side, okay? So that lets me know it kind of fits in with that right side bending picture in the lumbar spine. So I'm gonna have her lie with that. It's gonna be side bent right rotated left, so lie on your left side for me. And I'm just gonna derotate and really just check how her rotation is in that lumbar spine here. So scoot a little towards me. There we go, perfect. Okay, so she has a lot of tension built up at L4, L5. You okay?
Yeah.
Feel it?
I do.
Right there. And then I check quadratus as well. So there. So for students in the audience, what's the superior attachment of the quadratus lumborum? You can yell it. 12th rib. Even our videographer knows. Pull your hip back against me. 3, 2, 1, and relax. What's the inferior attachment? Bring your hip back. 3, 2. Anyone can yell it and relax. Yep, iliac crest. And relax. And let's just check the other side for funsies here. What is the medial attachment? Anyone? Medial attachment of the QL? Good. Not too bad. So I'm just going to do some soft tissue here. Good answer. The transverse processes of the lumbar spine. What is the lateral attachment of the QL? And it's crickets, right? It's a trick question. There is no lateral attachment. Bring your hip backward and then relax. Good. And then again. And relax. Okay. And then on your back here. So with the QL, I often find with any lumbar dysfunction, inevitably the quadratus is involved due to its stability components in the lumbar spine. So now I recheck that side shift. She's now straight up and down. Next, I like to move to the abdomen and the rectus and the respiratory diaphragm. So I do like a springing. She doesn't spring as well on this left side. And I find this left hemidiaphragm is restricted. So in treating a hemidiaphragm only on one side, sometimes I'll get all of my fingers involved. You okay?
Mm-hmm.
Some people do not like this very much. So take a deep breath in because it's very tender and relax. Follow that exhalation. So this is a respiratory assist treatment. Deep breath in, I'm resisting. Exhalation, I'm following. And then keep going, very good. And relax. So I'm redoming this left respiratory diaphragm. And I'm kind of aiming towards the back of her rib cage. Keep going, good, good. Not springing nicely now. There's a technique Dr. Fulford liked to use. He's one of the mentors that I never actually met in person. But he does his fingers in a line down the linea alba, feels for that kind of bowstring from that xiphoid to the pubic bone that can hold your rib cage closed from the anterior surface here. You okay?
Mm-hmm.
Is this pretty tender right here?
A little bit.
A little bit?
Yeah.
How's the right side?
A little bit more tender.
Yeah, so I don't want to just dig into her abdominal aorta. That's a sensitive area. So I kind of find both sides of it, and she is more restricted on this side. So I'm just kind of allowing my fingers to sink in with her breathing. Some osteopaths call this like a trauma release. Sometimes if someone had an accident or is undergoing a stressful situation, they can store a lot of tension in this area. So I'm just kind of helping that to resolve. Do you guys know how I know that I'm done with these techniques? Like, how do I know that I can move on? Any ideas? When the creep stops? Yeah, pretty much. It's when I feel the tissue respond or when I feel it release to its maximal ability at that time. Again, it's like a sense thing where you just know, you can feel the tissue releasing, and it could be a sense of like warmth, it could be a sense of motion, it could just be like a deep breath that the patient has. Now I'm in the thoracic inlet. So she has a left rotated thoracic inlet. Now I'm just kind of going like a steering wheel. My hands are on the coracoid process in the front. My thumbs in the back are on the trapezius fibers, as well as like the posterior part of the first rib. And she also has an elevated first rib on that same side where she has a lot of her neck pain. So I'm going to check her cervical spine as well. Any questions from you guys while I'm up here? Here we go. Just watching the movie taking place, right? No? I have a question. Yeah. Can I go back? How much are you going to pay me? Oh. Just kidding. My Venmo is at Dr. Alex. Yeah, yeah. I also accept food. Food or caffeine I accept. So I'm checking the subocciput. Definitely a lot of tension on both sides. So I'm just doing some soft tissue MFR work here. Really trying to influence that chin to be in a tucked position to try to eliminate some of that cervical extension that inevitably will happen when muscles tighten up back here. So really I'm at the insertion of the trapezius, splenius capitis, cervicis, rectus obliquus, all those small little tiny muscles. Okay, so as we check here, check some, do some muscle energy here. Try to side bend this left ear to the left shoulder. 3, 2, 1, and relax. Do that again, and relax. And one more, and good. Okay, let's check this other side. So side bending, right? So what are the main side benders of the cervical spine? And to the right, and relax. Those are some. What are the other ones? And relax. Yep, and relax. How many scalenes do we have? Your middle. That's right. Good job. Zach knows his anatomy. Good job. I will give you a pass on your rotation. All right. And then an extra credit for filming. All right. So this is a technique, if you want to swing around to this side, my mentor taught me. You guys can come a lot closer if you want. I don't bite. So
I do.
yeah, that's why I'm being very gentle with Dr. Rubin. So fingers are on the medial border of the scapula. This finger specifically is on the insertion of the levator scapula. This finger, this thumb, is going to be on the clavicular insertion of the trapezius. I'm framing the scapula with this left hand. I bring this arm into adduction and across to the other side. As I do that, I'm pulling towards me, and I feel some snappiness happening in the, I guess you could call it that scapular thoracic joint here. And then bring your elbow towards me. 3, 2, and relax. So I'm turning it into muscle energy. And again, and relax as I kind of pull laterally. And one more, and relax. So this is really targeting the rhomboids, right, and the medial scapular muscles and the trapezius a little bit. I can also pinch the trap and use this arm as like a long lever control for the whole scapula. And as I'm really investigating with my left hand up the trapezius, let's say I was in my clinic and I had a bunch of needles available, I would also maybe consider dry needling or maybe consider acupuncture for these type muscles, because they can also really influence the tone of the muscle to allow that referred pain and that headache to release as well. So, you okay? Okay. So I'm making my way up to the trap here. Next technique I would do is like a pec release. So felt a lot of tension at the coracoid process. So remember, the pec minor attaches to that process, which is an anterior hook that is part of the scapula, and it is pulling to ribs 3 through 5. So to get there, sorry if you're ticklish, I get my thumb under the pec major towards ribs 3 to 5, and I'm trying to find for these bands of the pec minor. And you can kind of, if you wanted, play them like a guitar. You're almost like strumming here with your thumb. You okay?
Yeah.
And then I'm trying to release those fibers off of the rib cage. That's going to bring the shoulder from being protracted and that thoracic inlet from being rotated to the left into a more retracted position, thus allowing for less strain on the scalene and on the trap and on the levator, right? So as that releases, I'm also going to check the lat and teres attachments onto the humerus. So I switch my hands into this position, and I'm essentially into the posterior axillary fold like so. And again, this stuff, patients could be like, I didn't even know that was there. And like, oh my God, why is that so tender? Well, it's because the lat is a big muscle. And the lat does a lot of movements of the upper extremity, pulling, right? So I'm just releasing that. You can even swap to have your thumb on top if your fingers get tired. You okay?
Yeah, that's yeah,
it's really tender, right?
Yeah.
So this is something too you could consider doing, like a trigger point injection or dry needling or acupuncture on if it is really resistant. And you can even comb your way down the lat along the rib cage and follow it down to the lower ribs as well. So I'm just kind of releasing, bringing the arm into flexion, and working my way up through that tissue here. Okay? As we bring that down, then we recheck, right? So we want to recheck that thoracic inlet. And see, now this arm is dropped completely down, caudad, as well as retracted. Her thoracic inlet is derotated, but now I got to treat this side because it's almost like this side is high in comparison. She still has a slightly elevated first rib. So to treat that, I'm going to get my thumb on that first rib right here behind the clavicle. And then I'm going to create some slack in the tissue by bringing her head there. And then I'll have her just take some deep breaths. So I'm blocking with my thumb. And as she exhales, I follow that. Keep going. Good. Deep breath in and out. And I just keep going. Deep breath in. Good. Blocking, going with that. And then release. Good. And then we reassess here. So getting better. I got to do the other side. So all of this is an integrated approach for the neck, starting all the way down there, right? Because if I just treat her neck by itself, maybe it's good if I only have 5-10 minutes and it gives them some relief. But my goal is for her to not have to see me so often by addressing everything else if given the time. So we have plenty of time, so I have plenty of places to treat here. So bring your elbow towards me, 3, 2, and relax. And again, and relax. One more, and relax. So I also have to keep in mind her chronic things everywhere. So she had a biceps tendonitis on this side. So I'm going to be pretty ginger about when I go to that pec minor, because guess what also attaches to the pec, or to the coracoid process? Any guesses? Short head of, dude, this guy's on fire. Short head of the bicep. Where does the long head attach? Up in the shoulder. And it doesn't attach there, it goes through there. Where does it end up? Any ortho people would love this answer. Anyone? That was short head. What's the long head? Where does it go? She wants to do sports med, guys, so she should know this. It rhymes with mabrum. The labrum. So the long head of the biceps becomes the labrum inside of that glenohumeral joint. The glenoid is a surface off the scapula with a little cup of cartilage on there that is the articulation between the glenoid and that humerus. So when we have a SLAP lesion, a superior labral tear, that is because there's a lot of pressure on that biceps tendon, bringing it anteriorly and quite literally pulling it off of that labrum. Does anyone know what test would be positive in physical exam for a labral tear? That's supraspinatus, but close. Yeah, how do we do that? Bring your thumb down and across. Can you push up? Any pain?
Yeah.
She has pain with O'Brien's. So that makes me suspicious of any type of labral pathology, right? Not what she would love to hear, but now I'm being careful here, right? So this is her, it's tender. So to not irritate it too much, I'm gonna try to avoid that bicipital groove in that biceps tendon and work around it. Now we're releasing this pec minor, you okay? We're getting here. And then we check the labrum, or sorry, not labrum, the lat. Here. Any questions from the audience while I'm working on this? Okay. All right. So we've cleared a lot of the body here. So now we start to work up here. Okay, I want to scoot a little bit down for me, like about a foot. Yeah, perfect. So we're going to get to the cranium soon. Yeah. It's a really great question. Yeah, I do not, because I find I could treat 10 regions in 5 minutes if I wanted to. The way to maximize regional treatment is by treating transition zones. If I treated just the thoracic inlet, I'm hitting rib, I'm hitting upper extremity, I'm hitting cervical spine. So that's a bunch of regions right there. If I also treated pelvic diaphragm, pelvic floor, that's hitting like another 2 to 3, 4 regions. So in doing all of that, I think if you build for time, you might get reimbursed a little less. If you just build for 10 regions and you can show the diagnoses, the treatments, and just say like, here's what we did in this time frame, then I think it might be more beneficial. So yeah, all that to say is I do like regional codes. Yeah. If yeah. So as is 3. If I have, and I'm just doing some suboccipital release here. If I have 10 minutes to treat, I can typically hit 5 to 7 regions. If I have 20 minutes, I'm hitting 10 almost every time. Mhm. Mhm. Now we're going to do some, this is like one of my favorite cervical techniques. We're going to do some contralateral cervical, they call it like a soft tissue. There's a little bit of a traction component, but I'm hooking my fingers, trying to get between the paraspinal cervical muscles and the spinous process, and I'm pulling up to me, like up towards the ceiling. I'm stabilizing using the greater wings of the sphenoid here, and I am just literally working through that tissue. Nice and rhythmically. Doing okay?
Mm-hmm.
Yeah.
Actually feels good.
Yeah. This is really very kind of dense chronic muscle that I'm feeling here. So just doing that over time. I want to swap to the other side. We'll do the other side. Mm-hmm. There we go. So this side also has pretty similar level of chronicity here. There we go. There we go. Good. Let's check here. This is what I call a pizza pan test. I slide my hands under the thoracics and I spring up to determine some rotational components. So if I spring up, I notice that she is indeed rotated to the right on that side in the upper thoracics because I'm not getting as good of a spring to the ceiling here. So if we're gonna do some, I guess you could call it HVLA, but I just more position the fulcrum and add pressure. And then if things, start to adjust on their own, then so be it. But I also don't want to break this table. These tables sometimes have a little bit of a thin backing to it. So I call this kind of like articulatory HVLA, where I'm springing her, I guess you could call it like that rib, that costal thoracic joint here into my thenar eminence here. So because it is so tight, we don't hear an articulation, but again, like the book says, it doesn't mean it was ineffective if you don't hear a giant clunk happening.
I felt it.
Yeah, so she was feeling that localized thing, and now we're even. So here we go. And then check here. Recheck some motion here. Good. Let's just check each segment. Checking some flexion too. So you always want to check in both flexion and extension. These are type 2-like segments. Good. Then here's where the real fun is checking her cranial vault. So a lot of people kind of skip this part because either there's a time constraint or they're just not comfortable. But I think it's important, right? With a headache component, with a cervical component, inevitably the cranium is going to be involved. So I think at the very minimum, you see what her rhythm is doing, and you see if there's any glaring somatic dysfunctions going on. Luckily for her, I'm not detecting any like major hangups. She's got pretty even CRI. The rate, I don't want to guess at this moment or say, because I still pretty early in what I'm sensing here. But I wouldn't say she just got a head, TBI or head injury or anything. I'm not really feeling much of that. Have you had any major head traumas or anything?
No.
Yeah. When I do feel a patient that has that, you can really detect like if there's a vertical strain or a lateral strain or some kind of side bending rotation pattern, or really detecting from where they were hit. You can kind of sense that force vector through the cranium. So vault hold feels pretty good. I like this hold where I float C1 under, and you get a nice feeling for the frontal and occipital bones here, and how they kind of open up with flexion and then come together with some extension of the cranium. So I'm just kind of, really a lot of what I do cranially is just being there. I'm not adding too much force. I'm just kind of feeling that CRI and tide motion happen, and then, yeah. Yeah. Oh yeah. People are like, "What is going on?" Yeah, they might not have learned this yet. They'll say that after you have the class. Yeah. Now another hand hold is called Becker, which I really like because it's very simple. You make your hands into a bowl like this, and you're feeling that like wobbly motion happening within your hands. That you could end up trying to balance by some subtle pressure differentials and changes, or you can just sit here and listen too. But I really would encourage you to conform your hands in with their system, if you could say. So trying to lose the border between your hands and the patient's cranium is often how the treatment can happen and be facilitated. So I'm not really trying to impart anything. I'm just here as like a witness to what is happening, and no judgment, nothing really. I'm just kind of hanging out and sensing what her system is doing. Now, what you might sense is increase in pulsation. So that pulsation increase is really the capillaries expanding and our parasympathetics kicking in. So you might sense that. You could also sense some tissue starting to loosen. Maybe the epicranial fascia becomes a lot less dense and restricted, therefore allowing more blood flow through the sinuses, and allowing a little bit more motion with the sinuses and the tent and the falx, or the balanced membranous component of the cranial vault. You could also feel the sutures opening up a little bit too. A lot of people get this occipitomastoid compression because of where the anatomical location is with regard to the trapezius muscle insertion points. So all that to say is just be present and just feel what you feel, and patient kind of does the rest. Another good hold that I like to do is an occipitosphenoid hold. So one hand under the occiput, you come out laterally a little bit, and then you have this other hand on the sphenoid. Now this one is nice because you can actually bring the sphenoid into a point of balance using my thumb and my ring finger here. And I can even do a slight lift anteriorly as well if I feel like that sphenoid is compressed towards the back. So another way to monitor. And then I'll just reassess and vault hold. So overall, I feel like she has really good cranial rhythm. Luckily for her, very symmetrical cranial vault. Nothing super drastic other than a slight right side bending rotation, which is a pretty physiologic strain that she could have just had forever. So other than that, I'll just recheck. That feels pretty good. And check from all the way down where we started. And I'm guessing that the treatment took 23 minutes and 32 seconds. Is that right?
29:20.
I was talking too much. How does our patient feel?
I feel much better.
Cool.
Yeah.
See, it sells itself, right?
Yes.
So if
Better
she was
range of motion.
there you go.
Yeah.
If she was a patient in my office, be like, okay, I'll see you in a couple weeks, maybe in a month. Do their home exercises that you maybe give them, stretches, physical therapy. But for the rest of the day, she's just got to hydrate and take it easy. Any questions?
No.
No? All right. Thank you. Bye-bye.